Hello everyone and welcome. I'm Cora Peck, and I'm with the Pudendal Neuralgia Association, which is a nonprofit organization dedicated to education, awareness, and support for those with pudendal neuralgia.
Wow.
Today, we're honored to be joined by Professor Oskar Aszmann, Professor of Plastic and Reconstructive Surgery at the University of Vienna, and an internationally recognized expert in peripheral nerve reconstruction. He directs the Laboratory for Extremity Reconstruction and Rehabilitation, where his work focuses on nerve anatomy, functional restoration, and innovative surgical approaches to complex nerve injuries. Professor Osmond's background in neurophysiology and reconstructive microsurgery brings a uniquely precise perspective to pudendal neuralgia. In today's webinar, he'll discuss how he evaluates patients, distinguishes true nerve-generated pain, and determines when surgical intervention may be appropriate. Professor Osmond, thank you for being here. It's a privilege to have you with us, and I'll now turn it over to you for your presentation.
Thank you, Cora. Thank you for inviting me to this forum. I want to introduce myself a little bit more than you already did. I am a plastic surgeon, you already said that, with a very strong focus on peripheral nerve surgery. I did a PhD also at Johns Hopkins, Maryland, for many years ago, but I think 30, 40 years ago. On neurobiology, and this is where I also met Lee Dellen, my old mentor there. And the reason why I am particularly interested in the pudendal nerve is because my very first patient that we encountered having pudendal nerve pain was a patient in Baltimore who had a pelvic ring fracture, and that's about maybe 35, 40 years ago. And we were wondering what the pain was that was bothering her. And then we realized that there is a nerve going through the pelvic floor that was basically trapped in the bone. And we were wondering how we could help this lady. And so we went to the anatomy laboratory and tried to figure out which nerves are related to that pain. And that is when this entire journey started with dealing with patients that had pain in the pelvic floor. And so after this experience, I think there was a long years of quiet. And then I don't remember exactly the date, but probably around 2003, because of our publications, there was various patients contacting me. I was already back here in Vienna with pelvic pain problems. And so the talk that I'm giving today is a summary of my experience over the last 25 years of dealing with patients who have come up with all kinds of trouble relating to the pudendal nerve. And so just to say that. So the anatomy, I think most of the people in this audience probably know the rough anatomy, but still I'll walk you through this again. The pudendal nerve is a very unique nerve, and it originates from the S1, S2, S3, S4 root. It is not only a nerve that contains somatosensory nerves, meaning nerves that relate sensation and motor fibers, but also they relate parts of the autonomous nervous system, which is the um, sympathetic and parasympathetic nervous system. And so this is a very complex nerve because it is a very deeply seated nerve with all different types of sensations that are being covered. And we will see that as we go through this talk. Um, the sacral plexus also gives rise to the largest nerve of the body, which is the sciatic nerve. And indeed, some of the patients who have pudendal nerve problems, they may also have problems relating to the posterior femoral cutaneous nerve, the cluneal nerves, or even actually also the sciatic nerve, meaning that some patients do have, like, let's just say, tingling in their feet, maybe even burning, or other sensations that radiate all the way down to their foot. So the fact that somebody may have pudendal nerve problems, but also problems in the sciatic nerve, only indicates that there may be a lesion, or it may indicate the site of the lesion more than that it may not be just a pudendal nerve problem. And um, so so here we see the critical anatomy surrounding the pudendal nerve, and you see here the piriformis muscle. And we see that the inferior gluteal nerve, the posterior femoral cutaneous nerve, the sciatic nerve, and the pudendal nerve are all covered by the piriformis muscle. That's the image to your right on the screen. Um, and so, which means that there are some patients actually that do have symptoms of an piriformis syndrome, which may entail problems of the pudendal nerve, but it may only have problems related to the sciatic nerve. Um, Now, the next part as to where it's getting relevant to pathology of the pudendal nerve is the little circle of the pink to the left. And this is where the pudendal nerve that is indicated green in the right image is going in between the sacrospinal and the sacrotuberal ligament. Now, if you look at this image, you may wonder, wow, there's lots of space in between these two ligaments, but in fact, there is not. And we will see this later on in some of the intraoperative pictures, where you will see that this space really is almost virtual. It's almost no space in between these two ligaments. And so this may indeed be a site of entrapment. What comes next is the Alcock's canal. And you can see on the image to your right the fascia of the levator ani, which is the strongest muscle in your pelvic floor, pulling up the anus. And you can see the internal obturator muscle and this tendinous arch of the levator ani. And in this image, you can also see this fascial duplication that may be a source of entrapment to that nerve. What you can also appreciate in this particular image is that, for example, here in this image, the rectal branch passes directly through the sacrotuberal ligament. Now, this is important to note because some patients have all the other two branches, meaning the perennial or the dorsal clitoral or the dorsal penile nerve, totally unaffected. However, the rectal branch may be entrapped in that ligament. And this is a rather frequent finding that it may not be the entire rectal branch, and it may only be smaller branches, like, for example, one branch that is not indicated in that image. But the coccygeal branch, which also passes or can pass through that ligament, may be entrapped right there. And here we see the ischiorrectal fossa on your right image. You see the levator ani. You see the facial duplication with a transverse section through the Alcock's canal. And I'll put my mouse there, and you can see here the pudendal nerve, or the different parts of the pudendal nerve, and the pudendal vessels, and the fascial duplication that denotes the Alcock's canal. Maybe I rehearse again. This is where my little arrow is. This is the transverse section through the Alcock's canal. This is the ischiorrectal fossa where all the fat is. And you see the fascial duplication. And on the left side to my screen, you can see the other two nerves that may be of importance. And these are the cluneal nerves. These are the inferior cluneal nerves, and then the superficial perennial nerves. Now, I'll say this at this point, and there may be other opportunities to talk about that. But when we talk about the perennial branches, we mainly talk about these branches here, which are the deep perennial branches coming from the pudendal nerve. But you need to know there's also superficial perennial branches that come off the PFCN, the posterior femoral cutaneous nerve, which then veer towards the scrotum in the man or the greater labia in the woman. And so There can be two sources of pain if patients have had either surgery in this region, or maybe a trauma, or maybe a baby, or some other traumatic event that may have torn or injured these nerves. So it may be the superficial perennial nerves, which normally relate towards the sitting bone and is more related to the cluneal nerves. And then there is deep perennial pain that radiates up to the vagina, or the labia more than that is nerve pain related to the pudendal nerve due to injury to the deep perennial nerves, just to differentiate between these two. Here again, this image is trying to denote the Alcock's canal, where this little arrow is. This is a space distal to the interligamentary space in between the sacrospinal and the sacrotuberal ligament. And this is a fascial duplication in this region. Now, on the right, you see an image related to the female genitalia, and then we see again the rectal branches, the perennial branches, and the dorsal clitoral branch. And again, the perennial branches that are indicated here are the deep perennial branches, and these are not the branches coming from the PFCN. And this again is a similar image denoting the complexity of the different nerves relating to the anogenital region. Now, this left image is important to note because uh, um, there's also nerves coming from the lumbar plexus, meaning from L1 to L4. And these are nerves, for example, the ilioinguinal nerve or the genitofemoral nerve, uh, or the iliohypogastric nerve that may also give rise to pain. And the specific history taking of each patient then basically leads the way as to where that pain may be related to. So, for example, if you had a mesh put in because of an inguinal hernia, or you had a tap repair, which is a mesh put in with a laparoscopic approach, there's different sets of nerves may be injured and may be giving rise to a pain syndrome. And this is definitely not a pudendal nerve problem. So, for example, pain that is also depicted in the non-criteria, pain in the pubic bone or above the pubic bone is normally not related to a pudendal nerve pain syndrome. So I think this image just shows you there's many different nerves in the anogenital region that may be affected, and we need to be almost like Sherlock Holmes trying to figure out as to what the story of the patient is and what nerves may have been affected, and we need to figure then out which of these nerves may need to be dealt with. So pudendal nerve compression syndrome, or let me just say lesions of the pudendal nerve, can have many reasons, and the symptoms of that are normally always related to either sensory, motor, and parasympathetic or sympathetic of loss of function. And that can be any of these. Um, or it may also be, let's just say, if I would compare a nerve compression syndrome of the pudendal nerve to a carpal tunnel syndrome. A carpal tunnel syndrome patients, the main symptoms that basically makes patients seek a doctor is pain. So patients that have a carpal tunnel syndrome, they would not even think of coming to the doctor if it's just a loss of sensation or loss of motor function of their hand. But the reason why they're seeking the advice of any physician is because they have pain in the hand. And normally that pain is very typical in the radiation or distribution of the median nerve. And so this is how we investigate pudendal nerve patients. We ask um, what were the first symptoms? How did the entire pain syndrome start? And how did it develop over time? One must never forget that, let's just say, you're a woman, you had a baby, you had an episiotomy. The first symptoms was pain in your perineal branches, and then you kind of like live with that for a number of months, maybe years, and then that entire pain syndrome starts to spread into the entire spectrum of the pudendal nerve. And so that means that maybe a year after the onset of symptoms, you may say, well, my entire anogenital region is at fire. But the first symptoms has been pain in the perineal branch. So that means that you have referred pain in the other branches, but the first pain that you had is important to note. So this is important in your history taking or presenting your case to any doctor is that you try to remember what were the first symptoms. It may have been an infection, it may have been a trauma, it may have been giving birth to a baby, and the pain symptoms that were at the very beginning of that syndrome are important to note. And so that can be dysesthesias, numbness, spasms of the pelvic floor, urethral burning. So that is the reason why some of these patients, they think that they have had a urinary tract infection. And they may indeed have had one, but I'm just saying it may be similar to these problems that they have. Yes, and then these symptoms do increase with certain trigger movements, and that can be sitting, that can be bowel movement, urination, sexual intercourse, and so forth, or biking, let's just say. And so it's also important in your own history taking that you note as to what um, movements or what habits that you may have are increasing your pain syndrome and what helps you get rid of them. Um, the key anatomical compression points, I think that is one of the big historical progresses in treating nerve compression syndromes is that we know of the concept of double crush or the fact that nerves can be injured along the entire axis of a nerve axon. So, for example, if we stick with a simple carpal tunnel syndrome, if patients come and they say, "Doctor, my hand hurts, and especially these three fingers hurt," and then we, let's just say, do a carpal tunnel release, and the patient comes back 3 months later and says, I'm still in pain and it's not getting better, then we have to evaluate the entire neural axis of that nerve, meaning it could be an entrapment up here at the elbow, then it's a pronator syndrome, or it may be a cervical rib, which is way up in the neck, or it may be a compression syndrome at the exit of that nerve from the neuroforamina. And that is something that is known to peripheral nerve surgeons for a long time, that nerves can be entrapped or injured along the entire axis of that nerve. And so the same is true for the pudendal nerve. The pudendal nerve, as we know, comes from S1, S2, S3, S4, depending on what parts of we're addressing. So I haven't said that in the beginning, I'll say it now. The S1 and S2 root are majorly contributing to the rectal branch, S2, S3 to the perineal branch, and S3, S4 to the genitalia. And so that also is an indication whether it's mainly related to, let's just say, the labia or the clitoris or a deep vaginal pain, perineal pain, rectal pain. So that gives us a hint as to what part of the nerve actually is or may be entrapped or in danger. Now, as you know, there's, for example, Tarlov cysts, which are small cysts coming right from the neuroforamina. It is possible that you may have an entrapment of just one single root. Let's just say the S1 or S2 root. Now, if you were to have an entrapment at the exit of that nerve, right at the S1 or 2 root, so these would be these yellow uh, rootlets coming out from the sacral plexus. Well, then you may only have pain in the rectal area because this is what the S1 root does. And it may also extend because the S1 root also contributes to the sciatic nerve. It may also give you some, let's just say, dysesthesias in the foot, which is the same root. So we have to be very careful, again, like Sherlock Holmes, trying to find out where the nerve may be entrapped or injured and to which terminal organs that radiates. So that could be that. Now, if let's just say the entire pudendal nerve is entrapped in between these two ligaments here, between the sacrospinal and the sacrotuberal ligament, and again, this image, just for the sake of the image, is giving the impression that there's lots of space in between these two ligaments, but believe me, there is not a lot of space. It's a very tight space here, and it's very much possible that there is an entrapment right here. Well, then the patient must have a problems in all regions of the pudendal nerve, meaning from the genitalia to the vagina to the rectal branch. It may be in different intensities, it may differ from day to day, but in some way or form, all of these areas are related to that pain syndrome. So if a patient comes to me and he says, Doctor, I have pain in the rectum after defecation. When I sit long enough, I have perineal pain, and I may have pain during sexual intercourse, and maybe every once in a while I get numb in my penis, or I have persistent genital arousal in my clitoris. Then all of these regions of the pudendal nerve are in some way affected, and then it's already clear that it is not a root problem, but it is for sure a problem that relates the entire pudendal nerve in between these two ligaments. If the I jumped ahead. If the Alcock's canal is affected, then it may be a bit different because the Alcock's canal not necessarily always affects all branches at the same time. As you may know, that the pudendal nerve may exit after the interligamentary space here, and it divides, as it is seen here, in different terminal branches: the rectal branch, the perennial, and the clitoral branch. Let's just say a dorsal penile branch. And so it must not always be that all three of these are entrapped in the passage of the Alcock's canal. And then we come to the final area at the passage of these nerves through the urogenital diaphragm. And then there's different classics. So, for example, an episiotomy that is not then a nerve compression really, but it's a neurotomy and a neuroma that may form due to one of these terminal branches that are exquisitely painful, and they can trigger pain by pressing on that specific region where the nerve has been injured. Now, the same is true for the men, for example, if they do, let's just say, biking or racing biking, or they have had a biking accident where the saddle of the bike was pressing onto the pelvic floor. Some of them had a pelvic fracture. Some of them have a bony bump that has developed over time due to chronic repetitive stress in the region. And then the dorsal penile nerve may be entrapped. And we have described that many years ago that there is a very specific site of compression at the passage of the dorsal penile nerve through the urogenital diaphragm, right where the erectile bodies of the penis are pressing onto the infrapubic ramus of the bone. And so these are specific regions. And for example, if somebody has a compression of the dorsal penile nerve, then the consequence is intermittent or permanent numbness of the penis. However, the rectal branch or the perennial branches is not affected at all. So again, we get a hint as to a trigger point. We get a hint from the history of the patient that, for example, he is a bike rider. There may be a history of a pelvic fracture, and so forth. Maybe at birth of a baby that we know maybe there has been an injury to the perennial branches due to an episiotomy, which is a total different pain syndrome as, for example, a root compression of the S1 or S2 root. So when we evaluate patients, we have this in mind, and we ask specific questions as to where this may go, and then find appropriate solutions for that. Yes, and so depending on what I've just said, it may be mechanical, as I've just said, anatomical, congenital. It may be a tumor. It may be an anomaly that you are born with. There's many patients that have very strange pelvic anatomy, and so the sacrotuberal, the sacrospinal ligament are weird. They just look funny, and I can tell you over the last years, I've seen very strange pelvic formations and the nerve definitely being under a lot of tension when patients are sitting down, and there's a real tethering of the nerve as it comes around the sacrospinal ligament. So just so you know, traction injury or stretch injury of any nerve is always very uncomfortable. One of the most and the oldest nerve compression described is, for example, the ulnar nerve, which is right here at the elbow, and there's a little bone here. And many patients complain of it's called cubital tunnel syndrome. This is the second most common nerve compression of the upper extremity. And so, for example, when they are holding a newspaper or they're bending their arm, then they have pain radiating down to their little finger, and loss of sensation in their little finger. And that is just because the nerve is being stretched over the medial epicondyle. And so the consequence then would be to do an anterior transposition and to take the pressure out of that nerve. Pressure in regards to that there is a stretch traction injury to that nerve. And so the same is true also for the pudendal nerve. And so if you look at the anatomy, then you know that when you sit down and you flex the hip, then the nerve needs to come around this sacrospinal ligament. And there's a stretch injury. And most patients who have that, they will complain of progressive numbness, pain, tingling, all these strange sensations when they sit longer than a few minutes. And it also relieves when they're stretched out again on their bed. And so that is a very clear sign that there is a stretch traction slash compression injury of the pudendal nerve at the interligamentary space. So I've talked about trauma injury, childbirth related stretch injury. So that, for example, is if you have had a long delivery process, let's just say 20 hours of labor, and the head is being stuck in the pelvic floor and the head is pressing against the Alcock's canal. This for sure will injure or induce a stretch traction injury to the pudendal nerve at the pelvic floor and has a great potential of injuring that poor nerve as the baby's head is passing through the birth canal. Direct fractures, I go back here, fall of the buttock, sports injuries, and so forth. I've been talking about that. Scarring from repeated perineal pelvic interventions that could be, let's just say, a prostate cancer that has had surgery. It can be cysts that happen in that region, fistulations after Crohn's disease, smaller tumors that have been removed, all kinds of smaller interventions in the anogenital regions that may give rise to an injury to one of the branches of the pudendal nerve. Or here, for example, a tumor in the pelvic floor. Now, there is some nerve tumor related problems. We see them a lot here in Austria. It's called neurofibromatosis. It's a congenital disease, and they have lots of tumors in the pelvic floor. And so this is one of these patients. This is a schwannoma here. Uh, the next one is inflammatory, post-inflammatory, which is a very strange concept, but nevertheless true. If you have, let's just say, a chronic prostatitis or urinary tract infections, then the pudendal nerve may be affected by a neuritis, which is an inflammatory process of the nerves per se. So, for example, you've heard about a herpes zoster neuritis, which is an inflammatory process related to a nerve infection, if you will. And so any infection in that area can lead to a secondary neuritis of the related nerves, which in this case is the pudendal nerve. And any neuritis then will lead to some type of swelling or edema in the region, and the given space available to that nerve may be too small, and then a secondary nerve compression can be the consequence. So that means that that whatever you had, it could be, some transient infection of that in that region. It may have led to a neuritis. The neuritis makes the nerve swell. The given space is too small. A nerve compression is the consequence. And long after the infections is gone, still you're suffering because of the swelling of that nerve. And so in these cases, for example, surgery, I would think is not the first consequence, but an anti-inflammatory drug treatment to get the edema out of the nerve and to appease the nerve, let's just say with cortisone treatment. And then obviously we have dynamic factors, which are, for example, pelvic dysbalances because of some congenital malrotation of the pelvic bones. And so, for example, if you have morbus pertis, which is a congenital malformation of the hip, that very often has as a consequence a pudendal nerve problem because of the altered anatomy of the pelvis. So these are all reasons or can be reasons why patients end up with pudendal nerve problems. Now, many patients ask, why does it happen now when I'm 30 whatever years old or, uh, at a later stage in life? And this is just because they may have been born with a certain anomaly, but they can deal with that for a certain amount of years. But then after some time, the nerve just gives up, and pain and nerve dysfunctions is the consequence. It is very similar again to carpal tunnel. Most patients get carpal tunnel when they're 50 years old. However, they've always had a certain tendency to have a tight area in that region. It just shows up much later. Well, let's just say a cervical rib. I see patients probably every other week with a cervical rib due to um, and so then the nerve are very tight, and it's a very, very tight space. However, they don't have that problem when they're young, but they come to me when they're like 30, 40 years old, even though the cervical rib was always there. They always had it. It's a consequence after birth. It was just there, but only as time goes on, these problems manifest. So here again, we correlate what branches are affected with what pathology. And so we have the dorsal branch, as I said, with birth surgery, perennial, with a episiotomy or vestibulectomy, rectal branches after hemorrhoid surgery, episiotomy in the female, and for the male, we have, for example, Crohn's disease, hemorrhoid surgery, pelvic floor injury or surgery, weightlifting. I forgot to mention that, but for example, patients who have extensive weightlifting and they put a lot of pressure on their abdominal wall muscles, and then the pressure of the intraperitoneal cavity gets large, and then all the pressure basically gets relayed to the pelvic floor, and it may injure these nerves. And so that is one thing I tell patients before or after surgery, even the treatment, is try to avoid heavy lifting just because of the increased pressure in the abdomen, which may cause or give stretch traction injury to the pudendal nerve. So now we come to the diagnostics. As I've already mentioned in my last few minutes, that medical history taking, I think, is one of the most important things to do beyond even imaging or electrodiagnostic studies. I think to ask the right questions is important. And so that is, it's again, we need to be very inquisitive and ask as to what happened and when it happened and what was the clinical correlation to that. The non-criteria, you see them on your right. So these are these typical five major criteria that we have, which is a pain in the territory of the pudendal nerve. It is predominantly happening when sitting. We already talked about that. It does not wake you up at night. Um, this is a very strange phenomenon, but that is true for almost every pudendal nerve patients that I have met throughout the last 25 years, is that the pain goes away when they fall asleep. And when they wake up in the morning, the pain's gone, and it only starts when they're walking around or being active in life. The sensory impairment, I'm not really sure about that because there is certain scenarios where the sensory impairment is part of the pathology and definitely part of the treatment. I've mentioned it before, the patients who have, let's just say, an entrapment of the dorsal penile nerve, it definitely comes along with a loss of sensation or numbness in the penis. So numbness for me is not is not an essential criteria that is not supposed to be there. So some patients who have a pudendal neuropathy also end up with a sensory disturbance or loss of sensory function. And obviously pain relief by pudendal nerve block. We'll talk about the pudendal nerve block in a moment. So medical history taking non-criteria. Physical examination, I think, is also of utmost importance. So we need to know what the trigger points are and what under what circumstances the pain is being triggered as it is. Imaging, both high resolution ultrasound and magnetic resonance imaging are important foundations to come up with a diagnosis. As you know, there is a high resolution imaging is a 3 Tesla imaging, an MRN, MR neurography. It's just different sequences. It is not a specific machinery, but it's just another mathematical model that the radiologist needs to be aware of. And so there's certain centers in basically in every part of the world that know these sequences and they can do a proper imaging to get these nerves imaged properly. And so it should be a 3 Tesla MRI. Why 3 Tesla? Because the resolution and the granularity of the imaging is much more detailed with these images than with a 1.5 Tesla machine. One thing is important that whenever you do these images, and I'm sure you are being told that by the radiologist, you should be perfectly still while doing that. So try not to move around too much because then these images will be blurry. Diagnostic blocks, I think these are important. Now, I need to say that diagnostic blocks are being done differently in every country. Most of the diagnostic blocks in the world are being done CT guided. I personally think this is not the best way of doing that because the only thing you visualize is the bone because it's a CT, so you don't really see the nerve. And really, you don't know where your needle goes, except that you know that right there where the sciatic bone is, that's where the nerve should be. Um, but it's an indirect method, and it may either injure the nerve or you may not have a block at all. So there's many nerve blocks or patients that come to my office and I ask, did you have a nerve block done? And they say yes. And then I ask, well, were you numb after the infiltration, meaning that your anogenital region go numb? And they will say no. Well, then that was not a pudendal nerve block. And the other mistake that is being made is if the pudendal nerve block is done or the block is being done right where the pain is. So if the patient says they have vaginal pain and then they go to an anesthesiology clinic and they inject right where the pain is in the vagina, well, then you know nothing because then obviously the vagina goes numb, but it may not be related to the nerve, but it's just that the region is numb, but that doesn't mean anything. So pudendal nerve block is done by selectively targeting the pudendal nerve actually far away from where the pain actually appears. So if you have rectal pain and you have a pudendal nerve block done to the pudendal nerve directly far away from the rectum, but then the pain in the rectum subsides or goes away, then you know that it was a positive pudendal nerve block. The way we do this here in Vienna, and I think most clinics started to pick this up, we use an electromodulated nerve block, which is a fine needle. And at the tip of the needle, every second there is a small electric pulse being delivered. And when the needle approaches the nerve, it doesn't even touch the nerve yet, but it approaches the nerve, then the patient will tell me, this is exactly where it's painful, or this is where the pain is. And then that's where we inject a very small amount of local anesthesia, which is normally not more than maybe two milliliters of lidocaine. And then if that's positive and the patient says, now I'm numb in the region, then it is a successful pudendal nerve block. Yes, and then I think this is part of the general workup. So we do expect the patients to have had their gynecological, urological, proctological, and so forth workups. Infectious disease may sometimes be an issue. As already noticed, herpes can lead to neuritis, and there's others that may lead to chronic nerve problems. And I think the most prevalent, at least here in Europe, is Lyme's disease. Um, And so that can be diagnosed with an antigen workup in your blood. This is called a borreliosis. I don't know if you've had this, it's the same word in the US. Um, but this is a something that is being transmitted through a tick's bite. And so there is quite a few patients here in Europe that suffer from chronic pudendal nerve problems due to a tick infection, tick-related infection to borreliosis. And so you may have that checked. And that actually is very easy to treat by giving a 6-week dose of cyclin, which is a antibiotic. Nutcracker syndrome, I think, is something that is overly rated. Many patients that come to us already having had either stents put into their pelvic floor or other procedures trying to alleviate the venous load. However, I think it's an overrated pathology because having a congested pelvic floor is something totally different from having a dilated pelvic vein, for example, overlying one of these nerves, but it's definitely not a nutcracker syndrome per se. And then we have autoimmune or inflammatory diseases like endometriosis, Crohn's disease, Hashimoto grafts. So these are autoimmune diseases like morbus Bechterew, which may also sometimes be related to a pudendal neuralgia. 3 Tesla, we talked about this already before. Here you see the enhancement indicating an inflamed pudendal nerve. To the right, I'll just show you what. So this is a brachial plexus to the right, this black and white image, and you can see I'll put my arrow there. So these 2 small little dark dots are small torsions of the suprascapular nerve in the neck. But just to show you what is possible with a good MRI machine, you can pinpoint the site of the lesion very, very clearly. So these lesions are only about 1 or 2 millimeters large, and you can see that this lesion can be clearly visualized with a good MRI imaging technique. So if you have a pudendal nerve problem and you're looking into MRI, try to get a good institution, one that is known for diagnosing pudendal nerve problems. It's not only the machine that makes the miracle, but it's also the doctors who know the anatomy of the region very well. And so they can see the nerve, but they can also interpret the findings quite well. Um, and so I think it's important to find a good radiological institution um, who can do these imaging well. Yes, treatment. I'm sure you all know that, but I'll still walk you through these. So the first line of defense is oral pharmacological treatment. So these are either the group of antidepressants, so amitriptyline, duloxetine, that are often combined with pregabalin or Lyrica, anticonvulsants, which is gabapentin and Lyrica. These are all medications that are working on the central nervous system. So they're not drugs that work on the peripheral nervous system, but they work on the central nervous system. Then we have muscle relaxants. These are important drugs if you suffer from pelvic floor spasms or a hypotonicity of the pelvic floor, and it may help to take out the stress and the pressure of these spastic muscles. And then suppositories that I think in the US you can get mixed suppositories with ketamine, amitriptyline, and gabapentin. These are unfortunately not available here in Europe, but I think in the US you can get these. And in Europe we have the Stesolid, which is a benzodiazepine as a suppository. So these are all medications of the first moment, if you will, and there is many patients that are being helped by conservative treatment alone. Physiotherapy, I know there's many pelvic floor physiotherapists in the United States, and some of them are extremely well educated. However, I need to say a word of caution. too much manipulation of the pelvic floor may also harm or do harm. And so I would be careful to find a good physiotherapist of the pelvic floor because some just overdo it and you end up worse than you have been before going there. I think the most important thing is adaptation of work or living environment as it is. So, for example, a standing table, do not cushion change your work, your daily routine environment so you can live with the problem. And in many cases, this is what helps best. So if you have a pudendal nerve problem since only a few weeks, months, try to adapt your immediate environment as much as you can. And that also includes, working with your family, your husband, your wife, your kids, just to kind of like, so that the others are aware that there is a problem that you need to take care of. And obviously, psychological help. The infiltration, I talked about that. So we do not do here in Austria, at least in my practice, I don't do a CT guided or ultrasound. I use a electromodulated nerve block. I go through the pelvis, through the butt, and this intervention takes about not even 10 minutes, and it's an outpatient procedure, and you come and go. I have personally no experience with Botox injections, but I hear that in some patients it does work well. We do have two experienced radiologists here in Vienna who do that on a frequent basis, and they report good outcomes with that. Now, if indeed you have, let's just say, a hypertrophic obturator muscle or hypertrophic piriformis, I think there may be uh, it may be good to do that treatment into the piriformis or the obturator just to weaken that muscle a bit so that the nerve may have more space. But I personally have no experience with that. Operative treatment. So these are the treatments that I personally offer. So this is a transgluteal pudendal nerve decompression, which we do in patients where we have a proven compression or lesion at the proximal end of the pudendal nerve, which is mainly from the infrapiriformis foramen until the interligamentary space into the Alcock's canal. So these are all the regions that we can oversee during that type of surgery. Then we have a transperineal or pudendal neurolysis neurectomy. These are interventions that are mainly done in female after, let's just say, a difficult birth, an episiotomy, a cyst removal or whatever at the perineal region. And then the last one is a distal neurolysis at the urogenital diaphragm, which is, as it already indicated, only in men, where the dorsal penile nerve is passing through the urogenital diaphragm at the erectile tissues of the penis. Transgluteal approach. This was first described by Robert. I think I don't need to tell this audience what that is. This is the way I do this. I follow the muscles of the greater the gluteus maximus. It's a surgery that takes me for one side about 45 minutes to an hour. It allows me to visualize the entire pudendal nerve from the sacral plexus through the foramen infrapiriformis into the Alcock's canal. And I think it's the best way to visualize the entire stretch of the pudendal nerve along this entire region. Now we go into, I think, three case presentations. Here, for example, a 30-year-old patient, a bicycle crash 2 years prior, a fractured sacrum, initially no pudendal symptoms, and the gradual onset after 3 months. Now, this is particularly of interest because the scar after any of these things only forms after a few weeks or months. So, for example, you may have had a surgery and then everything was okay, and then maybe 3 months your pain starts. Then, with all probability, this is a scar that is troubling your pudendal nerve because in the beginning the scar isn't there, and then after 3 months there is a catchy scar that may entrap your nerve. And so, in history taken, we need to listen to this careful. And if the patient tells me that, then I already know then there's something wrong with the pudendal nerve. And then we see the MRI shows a unilateral pudendal nerve swelling at the interligamentary space. And this is the intraoperative approach through a transgluteal approach. And I'll move my little arrow right here, and you see this white structure overlying this is the pudendal nerve being looped. This is the sacrotuberal ligament, and then you see it's impinging, and the nerve is very swollen up here, and then it's flattened almost to nothing at the interligamentary passage. And we've removed that part of the ligament. We normally do not remove the entire sacrotuberal ligament in these cases, but only that part that impinges on the nerve. Now, I need to say this because this is a frequent question about instability of the hip. If, let's just say, the entire sacrotuberal ligament is removed, you may not know that, but the sacrotuberal ligament basically is nothing else than the region of origin of the gluteus maximus, and it's a ligament that has no particular function in stabilizing the hip. The sacroiliac joint is a very, very strong joint, and it can function very well without any of these two ligaments. And so you must not be afraid that even if the entire ligament were to be cut, that you will end up with some type of sacral instability. That's nonsense. It's not. It's neither scientifically proven nor it could be explained in any way. So outcome, I think this is important to talk about that as well. I tell this to all my patients that they must not expect that it's going to go away within one day to the other. And again, this is very similar to the carpal tunnel. If we do a carpal tunnel release, yes, the patient he will notice immediately that something's changed. So there is an immediate effect of the surgery. And there may be that the pain in the hand goes away even within the next day. However, there will be residual symptoms that may bother you over the course of many months, and recovery, especially for the pudendal nerve, may be very slow. And I can tell you from experience, it comes in an undulating fashion. So you may improve tremendously after surgery, and then there will be a setback, let's just say 6 weeks after surgery, and then you will improve again. So it comes in waves as the nerve recovers to the distal organs. But you must not expect to be like a miracle and next day everything is good and you will wake up from surgery and all is well. So I personally have never seen that within 25 years of experience. However, I do need to tell you that if I talk to patients, for the majority of the patients I treat, after 2 or 3 years, they can function well, and the pain that they had is not where it used to be. And I say if the outcome of surgery is that you can live your life, you can take care of your kids, you can manage your wife or husband, and you can take care of your job, and it's at arm's length, it's somewhere you can manage it, and it's not possessing you, then I think it's a success. Success does not mean that it's going to go away to, you're not noticing it. So, for example, I have knee pain since many years, and it bothers me every once in a while, and it's there, but I can still function. So I think that's where it's supposed to be. You're doing okay, but you know that there is something wrong, but it's not controlling you. So this was this patient. Then there is here and another. Where am I going here? Oh, this is just as you can tell, I'm stimulating the nerve with the open surgery, and you can see that the bud is moving. And so even right after releasing the pudendal nerve, you can see that the nerve starts to function. And after you take off the compression, the nerve is doing quite okay. And so this is how we deal with that. This is a transperineal distal approach, and here we have, oops, I moved too quick. This is approach that we have described many years ago. And you can see this is, for example, a patient who has had a biking accident, and the bone, and you can see here the bone is right where the saddle would be running. And when we open up, oh, this is the entire story of it. then you see, for example, here in this case, that there is a neuroma formation right here, and there has been a very tight spot after we opened up that region. And we have published that in many different journals, so that there's a real recovery of sensation in these cases. This is why I said before that the non-criteria to say that the sensory aspects are not related if you have a pudendal nerve problem is just not true, because some of these patients do very much have numbness of their penis as a pudendal nerve problem. So here is the algorithm of pudendal neuropathy. We have done a study some years ago, and we have followed up 119 patients, 54 female, 64 male, 44 years average, chronic pelvic pain. The symptom distribution was anal pain, 65, genital pain, 50, perineal pain, 45. And as you can tell just from these numbers, there was multiple pain sites, even in one patient present. I'll go through these because of time, because it's too many slides, I think. So the etiology may be repetitive microtrauma, cycling, sitting, sports, most frequent cause of these, and so the study parameters was a 5-year follow-up. And so I think the most important slide is this, that of the 119 patients, only 41 could be followed up for a 5-year follow-up, which is a long time. So that's why we couldn't follow everybody. But the important message is that of these, 61% were in the operative group and 16, which is 39% in the non-operative. And you can see from this graph that all of them, both the surgical and the non-surgical, actually improved over time. However, some of them were converted into the surgical group, and these then improved dramatically as well. So the message is that we need to follow up both conservative and surgical treatment, but first we treat them conservatively, and some of them will just improve with conservative treatment to a level where they can live with that. And then there are some patients that cannot improve. And then with the given findings that I've mentioned before, these would be surgical candidates. And so I think there's maybe one or two more study cases, and then we'll give it over to questions and answers. So this is, I think, a patient who had a radical prostatectomy. He had mild incontinence. Then he had a sling put in with an osseous fixation. He has had several surgeries uh, related to the pudendal nerve. However, there was never a real relief of pain. And then he came to see me, and then you'll see that there has been the sling that was put in for the mild incontinence had screws placed into the pubic bone, and these screws were right next to the pudendal nerve with a bulging. And then you see here these screws, and here you see the pudendal nerve, and you see these little wires that come out impinging the pudendal nerve. So we've removed the screws, removed the wires, freed the nerve, and the patient was just fine after that. Here we see these screws. Here another guy, 35-year-old patient, an amateur racing cyclist for 15 years, chronic pulling pain, left more than right, with a bilateral tenderness. MRI shows diffuse scarring at the inferior pubic ramus. And then again, we are exploring the pudendal nerve at the inferior pubic ramus, and you can already see this whitish tissue here is a thick, heavy scar scarring the pudendal nerve. And then we free the nerve, remove the scar, do a neurolysis, and you see the swelling of the nerve. This is a normal size, and then it's almost twice the size here at the compression site. And we relieve the external pressure from off the nerve and do a neurolysis. This is another patient has an acetabular fracture, osteosynthesis, pain and dysesthesias. And then we see in the MRI a screw right through the infrapiriformis region. You see here is the sciatic spine. Here is the plating. Here's the screw. And here's the pudendal nerve right next to it. And so then we explore the sciatic nerve. We explore the pudendal nerve right next to that. And here we remove the tip of, you see the screw coming through here, and then relieving the symptoms of the patient. We're here a patient with a 60-year-old female with a bladder extirpation, meaning the bladder was taken out through a transvaginal approach. And here the clitoral branch was injured. She has had numerous surgeries to that region, never really focusing on the peripheral nerve. And then finally identifying the painful branch through a local anesthesia. Then here we have the scars of the multiple surgeries, identifying the neuroma, taking the neuroma out, and thus dealing with the pain. So in this case, the treatment was a selective neurotomy of the perineal branch, leading to healing of that patient. Or here another patient with an episiotomy after childbirth. You see here the vagina, here the episiotomy scar. And then you already can tell that there is a very tough tissue at exploration and palpation of the vaginal entrance. And you can see the pain region here. And when you open up, you see the perineal branch ending up in that horrible scar. And so removing that nerve then also takes care of the pain. Now, what do we do to the end of the nerve? We don't let it just sit there because it will make a new neuroma, obviously, but we take the nerve and we replace it into the depth of the Alcock's canal where it can no longer bother the patient. So I think this is important to note. So take-home messages, pain in the anogenital region can be of neural origin. I think this is important to note. This is why we talk here today. We need to differentiate between proximal versus distal lesions. It can be a neuroma, it can be an entrapment. Uh, so all of these are within the options. The diagnosis is first and foremost clinical. Now, this is an important message also because sometimes we don't see anything in the MRI, but the clinical diagnosis is so clear that in the end, we do operate patients without having any indication in the MRI that there's something wrong. However, I still think that a good MRI will show these abnormalities, and that's why I also ask for it. However, if patients come to me and the MRI is without any findings, but the pain is very appropriately leading to the conclusion that it is of neural origin, I will still operate these patients. Stepwise treatment, I think I already talked about this. I think conservative treatment always comes first, physiotherapy, infiltration, and if surgery is refractory. The surgical options, we've talked about this, transgluteal decompression, distal neurolysis, or neurotomy, and a double crush is possible. I haven't talked about that yet, but yes, there are patients that have both a proximal entrapment and maybe also a distal problem. This is more bothersome in men than in female. However, it needs to be addressed if a patient, for example, let's just say, has had an episiotomy, but also has rectal problems, like let's just say a foreign body sensation after defecation, then one needs to consider that there is also at the same time a proximal entrapment. So have a certain number of patients that have both a distal and a proximal intervention. So the goal, I already talked about this, but I'll say it again because it is important, is meaningful pain reduction and functional improvement. It is not that you're ending up being totally pain-free. So I think this is an important message. So, and always consider differential diagnosis. Piriformis syndrome, I've talked about this, sciatic split, posterior femoral cutaneous nerve or cluneal nerve problems, and therefore patient selection is essential. That was a lot of slides and a lot of information, I understand, but I think it was important to get all that done. Thank you for your attention. Now we're ready for questions and answers, please.
Okay, well, thank you very much. That was an
You're
amazing
muted.
presentation. Can you hear me? Is that
Laura, you're
good?
muted.
I'm muted. How about now? Is that good?
I think you need to unmute yourself.
Uh-oh.
Ah, was I muted? Can you talk again?
Yep, I can. I'm good.
Okay,
Okay.
sorry. I turned off my phone because of the videos. Okay, sorry. It
No,
was my
no,
mistake.
you're good. Okay. So I'm going to go ahead and I'm just going to skim because I do think you covered a lot of the questions that were asked ahead of time. So just give me 1 second. I know you definitely covered this, but I just want to verify so people understand. So you only do the transgluteal approach. Is that correct? Do you do
No.
the perineal approach as well?
Yes. I do perennial approaches as needed. So if a patient comes with an episiotomy, let's just say, then and there's a neuroma, I definitely do a distal approach first,
Okay.
for sure. So, and also the cases that I've shown with, let's just say, a distal release from the dorsal penile branch. So these are also a distal approach. So I do whatever is needed, actually. The only thing I don't do is a laparoscopic release of the roots. So Mark Possover, I'm sure you know him
Yeah.
also as well. In Zurich, that's the surgery he does. I don't do.
Okay.
So I don't do a release of the rootlets.
Okay. And then for let's see, adequate access. Okay. There's a lot of questions and confusion in terms of what you can technically reach. So I'm gonna ask real quick because I remember you said from sacral plexus to Alcock's canal, you can reach that whole portion. So I'm gonna ask this. So in what circumstances can you follow into the ischiorectal fossa and decompress the inferior rectal nerve? And then for the distal portion, I know you already said, but the perineal approach is required. Is that
Yes,
correct?
correct. Yes. So I think the transgluteal approach allows a the largest distance of nerve inspection. So let's just say the pararectal approach that's also done in the United States in some clinics. It only allows vision of the pudendal nerve or the rectal branches in the Alcock's canal, but it does not address the pudendal nerve in the interligamentary space and proximal to that. And so when we do a transgluteal approach, it allows us the inspection of the entire Alcock's canal. In women, it is possible because they have a wider angle of the infrapubic region. We can almost go to the perineal region. In men, it's more difficult because they have a very tight pelvis. They don't need to give birth to babies, so it's a different geometry of the pelvic floor. There is a no man's land. There is a certain region of about 1 or 2 centimeters of space that we cannot visualize from a transgluteal approach. So there is a certain region of the Alcock's canal that I cannot reach in men, and even if we would explore these from a distal approach, I can also only get as far as where the erectile tissues of the penis attach to the pelvic floor. And then that's it. So there's about a 2 centimeter region that I cannot address neither distal nor proximal. But I need to say that this is not a region where the nerve actually can get in trouble because it's a very protected area, unless somebody has a tumor there, which in 30 years of practice, have never seen.
Okay. Um, there's a question about scar entrapment of the deep perineal and dorsal branches. Is decompression achievable at that point for you?
Yes. Now I would need to ask who asked that question, whether it's a female or a male. In the female, let's just say there's a scar entrapment of the deep perineal branches due to an episiotomy, let's just say. Then I think the correct approach to that problem would be to identify which of these branches are involved. And then probably the best solution would be to do a excision or a neurectomy of these nerves. And I can tell you in the past, I've tried also to save the nerve, just to do a neurolysis to keep the nerve alive. But for the most part, I've not been successful in getting rid of the pain. Okay. So the question was what to do when there is scar in the perennial branch. Yes.
Yeah.
So again, I need to differentiate whether it's the superficial or the deep perennial branches. The superficial perennial branches come from these are the longest from the cluneal nerves from the PFCN, but that can be differentiated with nerve blocks or with a clinical investigation. And if it's the deep perennial branches, let's just say you had an episiotomy being a woman, then it is the deep perennial branches, and so then these need to be relieved. And so I think the relief is not a neurolysis, but a real neurectomy that will take care of the problem.
And speaking of the PCFN, do you operate on these nerves as well?
Yes. So I've just recently had that conversation with somebody. I do operate the PFCN. However, for the most part, the pathology is not where the pain is, meaning at the sitting bone region or the deep cluneal nerves, but it is also very proximal at the infrapiriformis foramen. And yes, in some instances, so for example, if you had, let's just say, a fall on your butt, and you have, like in the MRI, you see there is some scarring over the entrance of the PFCN underneath the gluteus maximus at the tuberosity. Well, then this is where we address the nerve. But for the most part, I will try not to inflict another scar in that particular area of the sitting bone, because you know we try to stay away to do scars in the sitting region. So we can reach that nerve from the proximal end, from a transgluteal approach. Now, you see the scar over the butt, but it's not where you sit. It's over the butt, but it's away from the sitting area. And so we're trying to stay away from inflicting scars directly to the sitting bone because these tend to be problematic.
Okay. And do you utilize any nerve protection or anti-scarring adjuncts during or
Yes.
after surgery?
So the only thing I really believe in is the infiltration at the end of surgery with a low slow release corticosteroid because it will prevent scar formation in the critical period of about 6 weeks post-surgery. I do not believe in wrapping the nerve in anything. Now, I need to tell you that that has been tried in many instances, let's just say for the median nerve or other peripheral nerves, and it's just another barrier to healing. And whether it's a collagen or whether it's hyaluronidase or some other agents, I would rather stay away. The only other thing that I do is I take fat grafts around the nerve. Let's just say somebody comes and has had already one or two surgeries to the pudendal nerve, and there's a rescarring, which unfortunately does happen. And we really don't know why that happens, but it's about 3% of the patients. That's also true for carpal tunnel. So any peripheral nerve surgery that we do, there is a certain percentage. It's rare, but it happens where patients end up with a rescarring of their pudendal or some other nerve. And so in these instances, I take a fat graft that I put around the nerve, either as a free fat graft or as a vascularized tissue from the adjacent fat wrapping around the nerve. And it's not really a wrapping, but it's a protection against the rescarring because no nerve wants to be wrapped in anything.
Okay. And then speaking of scarring, what other complications or things can happen after decompression surgery? Um, is there any risk for anything, for
Yeah.
instance, and how do you manage
You
any
know, in
complications?
in surgery, there's certain principles that we know from many other regions. And so, for example, in hand surgery, when we do a nerve release or a tendon release or some other release, the most important message is early movement. And so that's why I encourage my patients to move very early. So the first post-operative day, my patients are up and running. I get them out of bed. And so I think it's important, even I'm not talking about squatting, but I'm talking about just moving around, moving your hip, maybe stepping some stairs, doing some small walking around, but not to stay in bed for a long amount of time, just to keep the nerve gliding. Because any type of post-operative exudation, like for example, some blood coming out or some seroma or some fluids that are around the nerve, they all are protein rich. That's just the way it is. And that will solidify if the nerve doesn't glide. And then you definitely will have another scar there. So we're trying to prevent that by early movement. And then, as I said before, I always put in cortisone at the end of surgery, not in the nerve, but around the nerve and the tissues around the nerve, just to prevent a scarring of the surrounding tissues that may entrap the nerve again.
And then in general, a lot of people want to know under what conditions would you accept patients? For instance, we have a few patients that have had PN for, 20 years, let's say. Would they still be a candidate for surgery?
Yes. So I'm aware of the concept of pain memory, and I understand that that may also be a reason not to do surgery because patients are already so used to the pain that they have there. But I can tell you that I've had patients after, so 20 years, I don't remember having a patient with 20 years, but like let's just say 8 years, 10 years, I definitely have patients that I treated after this amount of time and they are definitely improved. And so, and that is true. So, for example, I give you a funny story. I had a patient who has had for 5 years a chronic pain. It's not a pudendal nerve patient, but she had pain because of a dog bite of her leg. And and so we treated her with a very complex surgical procedure. And just about a week ago, I saw her and I was touching her leg and I was going there and she was frantic. She says, "Don't touch it." And I said, "Why? It's not painful." And then she looked at it and says, "Yes, you're right. It's not painful. I'm just used to having pain there so long." So that is what our brain does to us. It's kind of it has memory of pain and it relates to that. And then we need to unlearn that pain. But I can tell you, if you have a painful neuroma, let's just say in the vagina for whatever reason, and we remove that painful neuroma, that pain will be gone. And patients need to rehabilitate their pain memory.
Okay.
So I think so. 20 years, because you mentioned 20 years, I've
Yeah.
never had that, so I don't know. But 8, 10 years, yes.
Okay. And then another very common question we get, and it's kind of a two-part, but have you ever performed a repeat decompression surgery? So either, someone had laparoscopic surgery with
Yeah.
someone and then came to you, or even a transgluteal surgery and came to you.
Yes. Yeah, so that actually happens quite frequently. And so I think I need to differentiate. So there is patients that have had surgery and they may have had a surgery that was just wrong in the first place. So let's just say they have a pudendal nerve pain related to a tight interligamentary space, and they have had a laparoscopic surgery that you've just mentioned. Well, then I think it has been the wrong surgery for that particular patient. And so the problem still is there and it has never been dealt with. And so I've had a patient from Italy about 3 or 4 weeks ago. He has had 3 surgeries from 3 different surgeons with 3 different approaches, but the actual problem that he had was never dealt with. And so it was just 3 wrong indicate in a sense, it may have been, I told you about the double crush. So to simplify it, if a patient has a carpal tunnel, he may have a carpal tunnel and he has a surgery here, and then he says, "I'm still numb, it doesn't wake up." And then you realize, well, the problem is not here, but the problem is up here in the neck. And so it may have been a double crush. Yes, so part of the problem has improved, but not everything. So that happens also. The patient comes and says, "You know, doctor, I had 2 surgeries. 80% are gone, but then there's still this particular problem that makes me nuts and that hasn't been dealt with. Well, then we need to check whether there is an additional entrapment site that needs to be dealt with. And yes, then there is also the case where there is a real re-entrapment at the same site. So that happens also. Unfortunately, that's the 3% I was mentioning before. So it's now, so for these patients, I need to say I hate to do the same surgery twice over, but it does happen. And in certain scenarios, I think after the second time, I stop. I say, the only thing I can do is make you worse, because I may do the same surgery. It may address the right region. It's the appropriate surgery for your problem, but you just have a weird tendency to get worse again. So then, so then the only solution would be a fat grafting, as I mentioned before. And so again, this needs to be delineated. Has it been the same surgeon? Has it been the right problem? Is it a real rescarring? And so, and so again, I think after two surgeries, I would probably not touch the patient again.
Okay.
I would try to stay away because in the end, you may just make patients worse than they were, and you don't want that.
Yep. And
Mhm.
just so patients know for the post-op management, do you routinely place surgical drains after decompression surgery, and is a
Yes.
catheter required post-operatively?
Yeah. So I always put a drain in of
Okay.
both the distal and the proximal. But with regards to a catheter, I discuss this with the patient. So some patients have a tendency to get urinary tract infections, and they're very scared about a catheter. So I don't put a catheter in. But I make them aware of the fact that when they wake up from surgery, the first night, when they need to go pee, it may be difficult because they have maybe two drains in their hands and it may be painful and this and that and the other thing. It's night and so if there are normal patients without any history of urinary tract infections or no, kind of like, and they would say they hate having a catheter. I will probably put a catheter in just for them to have an easy night for the first night. But if they tell me that they have a strong aversion against the catheter and they have a tendency to get UTIs, then I would not do that.
Okay.
So it's negotiable. But
Right.
the drain is non-negotiable. I need to put that in because I'm always not afraid is the wrong word, but I'm concerned about having an effusion, a hematoma,
Okay.
which we always hate.
One patient asked specifically, many patients experience pelvic floor guarding when trying to sit after surgery. Do you have any recommendations for strategies to basically expand sitting tolerance without causing any flares?
Yeah, that's a difficult one. So as I said before, I try to get patients back on track as early as possible. But sitting is a difficult call because it is the most important trigger that we know. And so I do encourage patients to do sitting periods as well, but that's something I don't encourage within the first weeks after surgery so that they are particularly sitting in front of a computer screen or whatever. So I try to advocate, like I said before, with a stand-up table or, kind of like getting their environment ready for their problem. And so I do not encourage patients to sit for prolonged periods of time. However, I had a consultation this week with a radiologist actually, and he told me that he doesn't sit at all. And so he's just standing around and it's getting really troublesome for him because, we are in a sitting society. Most of the things we do are like I guess you're sitting here now and I'm sitting. And so this is an important mode of life as it is, and I think it's expected that eventually patients after surgery are also, uh, will also be able to sit again, to have, on a dinner table, let's just say, or in a work environment.
Right.
But I would be careful. I do not encourage that for prolonged amounts of time in the very beginning. And for the first few weeks, I wouldn't endorse it at all. Just stay away from sitting.
In your experience, can enlarged or meandering pelvic veins be a primary cause of pudendal nerve compression? And if so, um, do you identify vascular entrapment preoperatively?
Yes. Both yes. Vascular compression is a known compression phenomenon, not just for the pudendal nerve, but for every other nerve known to man. Uh, and and it's not only both arteries and veins can cause a compression syndrome. And I- um, the most within the space that we explore the pudendal nerve, there is some large veins coming across the pudendal nerve, and these we can identify in the MRI preoperatively. And when I say large veins, it's very obvious when you see the MRI. It's a huge piece of vein coming across the pudendal nerve. And so these we know you see that immediately when you explore the pudendal nerve, you see this big vein. It's as fat as my thumb, and then we just ligate it and take it out. And so there is no further compression. And that is actually not new. So, for example, the radial nerve, which is one of the nerves of the hand as well, it makes wrist extension and finger extension. There's called the leash of Henry. It's one of the oldest described nerve compressions of that particular nerve, and it's related to vessels coming across that nerve. And the consequence is you just take out these vessels. Now, veins are actually not that bad, but if the artery is sitting on top of a nerve, it's really troublesome because it's basically hammering with the pulse of the patient's heart on the nerve, and that can be very troublesome. And so if that's the case, we just take that artery out. There's many other arteries taken care of wherever in the pelvic floor, and you don't need these small arteries coming across the nerve, and we just take them out of no
And do
importance.
they ever reform
No.
after?
All
Okay.
right. So if you stent them like in with interventional radiology systems, they will come back in other ways or form. But if you take out the vein right on top, so I've had a lady from England, and she had a coiling.
Hmm.
She had a coiling of the vein. However, the coil then, which is a metal coil, it basically was just stuck on the pudendal nerve. So it made her even worse. And anytime she was sitting down, she felt that little metal ball, rubbing over her nerve. And so that's why I was saying I think if you have a venous problem and you see that in the MRI, I would advocate just take it out. You ligate it and take it out. It's the easiest and most successful way of treating that.
And do you use the operating microscope when addressing pathology on the smaller pudendal nerve
No.
branches?
Never, but I need to tell you this is almost a philosophy as it is because I never use a microscope in nerve surgery, whether it's, brachial plexus or whatever surgery. I always use loops, 4.5 magnification. That's more than enough. I only use the microscope when I do free tissue transfer. You suture vessels, and so these are very, very tiny threads that you need. But for nerve surgery, wherever it is in the human body, I only use loops.
And when you encounter branch level pathology, do you perform internal neuralysis, opening up the epineurium? And
Yes.
when is that situation appropriate?
Yes. So yesterday I've done a surgery on a guy who had a neuritis on a nerve, and then it is similar. It's a very hard and dense nerve. You touch it, it's almost like it's very hard, and then you do an epineuritis, and that's all I would ever do. And it's almost like a fasciotomy. You open it up with a very fine scalpel, and then you see the nerve is bulging out, and it's almost like an internal compression neuropathy. So it's the nerve is really stuck in its own connective tissue. And so then I slice wherever it's needed, and then you can see how the individual fascicles of the nerve are kind of like coming out of its pocket. And so, yes, I do believe in an epineurotomy. I do not believe in an internal neurolysis because, as you may know, you have these fascicles and you have the perineurium, which is the next layer in. And if you injure the perineurium, then you also injure the nerve within its kind of sacred little environment. And that is what we try to stay away from. But I do very much believe in an epineurotomy, meaning opening up the external sleeve of any peripheral nerve if needed.
And I know you mentioned earlier, I think it was I'm gonna get it wrong. I'm trying to find it because I had it written down to ask you for clarification. There we go. Okay, found it.
Mhm.
If intraoperatively you find nerve branches which are extensively scarred, under what circumstances do you perform a neurectomy? And are there any risks to doing so?
Mm. So if I see the nerve ending up in a scar, I will resect it. So I do tell patients if I see that the nerve may be close to the scar and maybe just taking the scar away is enough, then fine. But if I see the nerve is going, within the scar, I'll just take it away. Because I've had too many patients where I've tried the latter and it was not working out. So the patient comes back being in pain even a week after. And so I would much rather take the nerve out. And so, yes, the consequence is that because these are mostly sensory nerves, so there will be a sensory deficit. And so then patients will have a certain spot where they're numb, where they don't feel anything. And so then in some patients, they will start to hallucinate. What I'm saying is not they hallucinate, visually, but they will hallucinate certain sensations in that region that may be like ants crawling over the surface, and it may be some transient thing, and it needs maybe some medication for that time, like Lyrica or gabapentin, to appease the nerve in that region. But for the most parts, after about 6 weeks, that quiets down and the pain resolves and the hallucinations also go away. Um, so you understand when I say hallucination, what that means is meaning that the patient uh, thinks he feels something which is not really there. So
Okay.
you touch him and he's numb, but he feels that there is ants crawling, but it's not true. And it's just the brain kind of like making up for what has been lost. And so it's a phantom kind of sensation that they are producing. And that may be troublesome for a certain amount of time, but it's definitely much better than the pain they had before. And it only happens in rare patients. So it's for the most part, a neurotomy will lead to an immediate pain relief. And yes, it's you know s- so there is certain patients who develop real phantom pain. Not I'm talking about phantom sensation, what I just mentioned, but real phantom pain. And these are very difficult to treat, but these are rare patients. This is not the standard.
And I know you mentioned you put the nerve, because when you resect, right, you put it back into the Alcock's canal. Is that what you
Yes.
do?
Yeah.
Have you ever had a patient where you try to put it back together? Like if the
No.
patient is worse? Okay.
No. So um, so I could give you many instances where of failed surgeries, where that has been tried, even myself, trying to reconnect nerves and then ending up in a worse situation than before. You must not forget that when you put a nerve back together again, there is a regeneration process that is happening after that that may take up to a year, let's just say, for a smaller nerve. And during that process, that nerve kind of like figures out where he's belonging. And this is always, always, always a very painful process. So I've stopped trying. So that also in extremity reconstruction, I'm not reconnecting nerve. I take it. I mean, unless it's the median nerve, don't misunderstand. But if it's a smaller sensory branch, I will just take that out. I will not reconnect.
Okay. And for patients with comorbidities like endometriosis, Ehlers-Danlos syndrome? There's so many. How do you determine whether pudendal nerve surgery is appropriate and safe?
Yes, that's a very good question. So let's just say endometriosis. Many of these patients already had surgeries dealing with their endometriosis, or have had pharmacological treatment with progesterone or estrogens, you know. There is a remaining subset of patients that still suffer from pudendal neuralgia, despite the fact that they've had extensive treatments of gynecologists and related specialists. And so for these patients, the MRI, I think, is the most important tool to determine the way I'm going. And if there is no endometriosis seen anywhere near the pudendal nerve, then probably it's some other cause that causes that pain syndrome, and it's not the pudendal nerve. Because endometriosis is something you can see very clearly in the MRI. And so you can determine whether that's coming close to anywhere where the pudendal nerve branches are or not. Something that needs to be said at this point also is because some patients have deep-seated ovaries, and so when they're ovulating, they have a cycle-dependent pain. And if you look at the MRI, then you see that a large cyst, let's just say, that overlays the S1 or S2 root, which is very much possible. And then they have a pain that is cycle related. And then you can see that the ovaries are sitting right there on top of these roots. And then these are actually patients that should be referred to somebody who does laparoscopic exploration of the sacral plexus. Because then these ovaries are sitting right on top of the S1 or S2 root. And so that needs to be dealt with. That's a surgery I don't do. So that's something either here in Europe, there's, certain people I would refer them to.
Okay. And then do you have patients that have had transvaginal mesh that has caused PN? And how
Yes.
typical is mesh?
Yes.
Especially, they mentioned the rectal branch.
Yes. For either urinary or fecal incontinence, these meshes are put in for either mild or severe incontinence, and these indeed can directly injure the rectal or the perineal branches. And so I think either a high resolution ultrasound or MRI can give you a hint as to where these are connected and how these are injuring the nerve. Most of these are related to the Alcock's canal or the perennial branches. And so that I think you need to figure out with imaging or with a good clinical investigation. They will have trigger points that will know exactly where the pain is located. And I think that mesh needs to be either taken out entirely, which is very difficult to do because these meshes they interface a lot with the connective tissue that is there, and so you need to be very careful not to end up with a very severe incontinence after that type of surgery. So I would rather pinpoint which branch is affected and then either resect that branch, take it out, and leave the rest of the mesh inside, not to cause incontinence that is worse than they had before.
And how successful are the repeated surgeries that
How
in your
what? How?
experience?
How?
How successful are repeated surgeries in your experience?
Yeah, so I have bad outcomes and good outcomes for these. So I've had a recent case where he has had three surgeries previously, and we I was the fourth. It's so I said before I would not do that, but in some instances you kind of like you go the way just because they're so dire in their situation. And so this particular patient ended up well. But I can tell you for the most part, repeated surgery will, so these are very, for the most comes, poor outcomes. So there, in the most case, I wouldn't touch them. So I have had one recent patient with a recurrent problem, and I refused to see him. I said I will not do another surgery on him,
Okay.
just because I know that the outcome will be not promising.
Okay. And what's the average timeline of getting substantial surgical benefits?
Yes, so also important. I, as I said before, I think the immediate outcome, the patient should notice that the pain that they have been coming for to see me has been significantly altered, even within the first week after surgery. Again, it is not that the pain goes away entirely, but they notice a significant difference. And yes, the pain may still be there in a certain degree, but they know that there's a significant change in status. However, it takes a long time for these nerves to heal. So you need to know that the pudendal nerve is actually a very long nerve, and the nerve regenerates with a millimeter per day, which is 3 cent or an inch a month. And so it's a long road to go. And so, for the most part, I expect an immediate change in symptoms and then a slow recovery process over a time of a year. So I do not really give much attention when patients kind of like write me an email or call me and they say after 3 months and they say, well, things haven't changed at all, let's just say, or they are confused about this or that or the other thing. I say just give it time. It's going to recover. And for the most part, I think maybe 70%, 80% after a year, they will notice a huge difference. And again, keeping a pain diary, like writing things down as to how they are may help because people forget how much pain they were, let's just say a year before. And then there is certain patients that after 2, 3, 4 years, they write back and they say it's as bad as it was at when I saw you. That happens too, unfortunately, and this definitely is not something that we want to see, but these are these cases where they really do either have a rescarring. I currently have a patient that is suffering from that, and it's unfortunate, but that also unfortunately happens. But to answer your question, I think after a year, the patients should notice a significant difference of their original pain syndrome.
Okay. So we're going to do about three more questions. Two are going to be not surgery related, more for clarification. Um,
I need
well,
to be leaving in 5 minutes because I need to go home, but I think we
perfect.
can manage. Yeah.
Okay. So, for people that are sensitive to medication, do you have any suggestions for them if they want to try a medication?
And you mean that they're getting dizzy from it or vomiting or whatever? Is that what you
Yeah, they
asked?
just have, harder side effects, let's say, from medications. Is there
Yeah. So
any recommendation
this
for them?
this is difficult. Now you need to know that certain medications are not available in the United States, vice versa. And so I really don't know the market there as good as I know it here. So it may not be of help at all. But the standard medications that I've mentioned in my talk is what I think available also in the US. Um, Ketamine is an escape. So if patients do not work well with pregabalin or tramadol or Percocet, you would call it, um, then ketamine would be an alternative. However, this is a pretty severe drug, and I would not call it a first line medication. Other than that, I really cannot give you much help, because these are the classes of medication that I've mentioned in my talk. These are the classics everywhere in the world. And I think I know exactly what you're talking about. Some patients do react very strangely to some of these, and really there is no alternative, at least not that I know of. And ketamine is a reserve medication that I would only keep for, as a last line defense.
Okay. And then do you use steroids and PN blocks? Do you find them therapeutic or do
Yes.
you just
I
use
forgot to
lidocaine?
mention that actually in my talk also, but this is an important message. I have certain patients that come to me maybe once or twice a year to have an infiltration done to the pudendal nerve with a corticosteroid, and they're just doing fine with that for the rest of the year. And some really do recover to the point where they never see me again. So, so I think corticosteroid injections, both as a diagnostic tool, including a lidocaine, but also at the same time put in a corticosteroid can indeed be a therapeutic diagnostic infiltration. So it can be both at the same time. And I would advocate that for many patients. And you could see from my list, so unfortunately there was only, I don't know, remember how many patients it was in the end, but a certain amount really did very well with just conservative measures alone. So it is a good way forward.
And then the last question I have is for patients traveling to you internationally, what does the timeline look like in terms of the consultation, the evaluation, and then their stay after surgery and when they can go home?
So most patients, even if they have a bilateral intervention, they stay only in the hospital for 1 or 2 days. And it's not that they are walking out in pain and say, I need to leave the hospital because I don't know what, but because they're really doing well. So the day after surgery, they're up and running. I did a surgery yesterday, and the patient is leaving today. I think how late is it? He's already left, and he's flying back tomorrow morning. And so that is my standard. Most of the patients that come from, let's just say, United States, they stay here for a week just because they like Vienna and want to stroll the city, but it's not needed. I have patients that come from somewhere in Europe and they fly back the next day back to their country. And so that's it. Surgery takes about, let's just say, 1.5 hours for both sides if bilateral surgery is necessary. And there's no blood loss, there's no infection. Patients are generally, you know, healthy and happy the next day up. They get up and walk around. We pull the drains normally the first day after surgery, and if all is well, they go home.
And they don't have to do an evaluation or anything before the surgery appointment with you?
Oh, so so most of the patients I see the day before surgery. They fly in a day early, and then I see them in the evening before the surgery, and we have a conversation. We go through the details of surgery again. I look at the patient, I evaluate whatever needs to be evaluated, and then they surgeries next day, and then they're and if they stay a week in Vienna just because they want to see the city, then I can make another appointment before they fly home. So meaning, let's just say I do a surgery tomorrow is Wednesday. Oh no, tomorrow is Thursday. Then I would see them, let's just say, on Saturday or Sunday or Monday, and then they can fly home on Tuesday the week after. So it
Okay.
depends on how long they want to stay in the city.
Okay.
Okay.
All right. So
Good,
thank
Cora.
you
It
so
was very
much.
nice meeting you, and it was a very productive evening, I think, at least evening for me. And
Yes.
I wish you all the best, and we'll be in touch maybe. Yeah.
Yes, absolutely. Thank you so much. And I'm so sorry we went so late, but thank
No,
you
that's
very
okay.
much for your time.
Okay. You're
Okay.
welcome. Bye
Bye.
bye.